Okay, welcome everyone to another Monday VMR, and excited to be discussing with Alec today. Thanks to Simi and Vinny for making everything happen behind the scenes. And today we have a special guest from Bangalore, India. So I'm just going to allow her to introduce herself, and then we can get started with the case.
Hi everyone, I'm Kritika, as I already told. I'm from Bangalore. I'm doing my internal medicine residency currently. I'm in the third year, and I have given my step one and I cleared it. So, hoping to give the subsequent steps, and I hope to plan to residency in the US.
Okay, very nice, and best of luck on your journey. And do you have any hopes of subspecializing, or do you want to remain a, general internist in the end?
I'm interested in hemonc, so hoping to do that more.
Okay, very nice. Yeah, well, congratulations on where you are in your training, and I hope everything goes well with the steps and making the way in the arduous journey to the United States. But I hope that you have uh, success with that, and I'm sure you will, just given how driven you are to just to even come here to present a case to us. So yes, your connection is a little bit unstable, I would say. So if you're able to just turn off your video and you present just to try to avoid any technical issues that happens, that would be great. But if something happens, no worries, we'll work around it, of course. But yeah, I guess when we're ready, we could have the whiteboard pulled up and then we can get started. And Alec, you can take the first aliquot.
So, shall I go ahead with the case?
Yes, please do.
This is a case of a 19-year-old female. She presented with chief complaints of fever for 2 days and associated pain abdomen, vomiting, loose stools, and myalgia. So when she presented to the ER, when we checked her vitals, she had a temperature of 97.2 degree Fahrenheit, a BP of 60 mmHg systolic, a heart rate of 98 beats per minute, and a room air saturation of around 90% at room air, a respiratory rate of 22 cycles per minute. And on general examination, the patient looked sick. She had pallor, but there was no icterus at presentation. But subsequent days, she developed icterus. And on systemic examination, RS, there were bilateral normal vesicular breath sounds, no added sounds. And cardiovascular system examination was normal. On abdominal examination, abdomen was soft. There was tenderness in the left hypochondrial, in the umbilical, left lumbar, and iliac region, but there was no associated organomegaly. And urological examination was normal. Mm. Would you
Wow.
like to discuss?
Okay. Yeah, that's a a great first aliquot. Thanks so much. That's a lot of information. Um, yeah, I mean, so I think we have a really young woman here, 19 years old, coming in with an acute onset sort of systemic inflammatory syndrome characterized by some vomiting, loose stools, and myalgias. And so I think, we don't get a lot of background on this patient, but most of the time, 19-year-olds don't necessarily have a lot of background if they've been healthy their whole lives. But certainly, when I think of a 19-year-old woman coming in with a febrile syndrome, an infectious etiology is what first comes to mind. And then I start thinking about the severity of said infection. And I'm trying to discuss more about the presenting clinical syndrome, but the blood pressure is just pulling me away from that. So I think she has some abdominal pain, vomiting, loose stools. Certainly could localize it into the GI tract, but would definitely not want to miss anything in the GU or something from the lower thorax as well that could be contributing, or whether this is an exogenous organism like a virus or a rickettsial organism or something like that. But I think some more details about the history, if the stool was bloody or not, or exposures or travel may be relevant as well. And then where exactly this patient is living, I assume that would be in India, but I would love to know a little bit more about that. And then the patient's immune status as well, particularly in HIV tests. But as I move over to the vital signs, and I'll kind of discuss those and let Austin tackle the exam, but not currently febrile, but the blood pressure is 60 systolic. We don't even get a diastolic. So very concerned that this patient is in shock. And then most people that are in shock, the way that you compensate is by increasing your heart rate. And the heart rate is only 98 in a 19-year-old woman. That's not normal. 19-year-old women should be able to get their heart rates up near 200. So this is very concerning about whether there's a cardiac component to this, or whether this organism, has relative bradycardia, and we could talk about that. If this truly is infectious, what that might mean. And the patient is sort of tachypnic, but honestly, at least in the United States, the respiratory rate that's documented in the chart is the most inaccurate vital sign. So I don't necessarily know what to make of that unless I checked it myself. And then she is relatively hypoxic as well. So really, this patient is very, very systemically ill, very concerned that they're in shock, and we're going to have to figure out why. But that's my thoughts on the history. And then Austin, how are you thinking about all of that and the exam as well?
Yeah, beautiful. I think there's so many threads to pull on here, but as you said, like everything comes second to just the profound illnesses this patient experiencing in the form of shock. And so I think there's a few different ways to approach shock, but I think the classic sort of breakdown of, is there a distributive process going on? Is there obstructive process going on? Is there a cardiogenic process going on? Or is there an other bucket? I usually just bucket it as like an endocrinologic cause, like so I don't miss adrenal insufficiency or mixed edema coma or something like that. But I think in this particular case, we also maybe have a few ways to try to help localize things. And I think there's different paths to go. One is to say, as Alec, you picked up on, was like, hey, this person has hypoxemia plus a shock state. So should that take us to the thorax? But I think the tension in that is that we seem to have an abdominal syndrome occurring just based off of the patient's presentation, and in the physical exam noting that she has abdominal tenderness sort of on the left side, and then sort of the lower abdomen is sort of how I summarized what was going on. So one way today to do that is just to sort of like overlay shock with the sort of abdominal catastrophes that we like to use this FIFO mnemonic for. So is there a vascular phenomenon that could be happening? I think with the febrile potential illness that's going on here, then I'm going to prioritize that to be slightly less likely, but certainly cannot exclude it. Inflammation with the eye, is definitely in consideration here for sure. P being perforation, again, is possible, but I think we just need a little bit more information to help guide us here about exactly what's happening. And then E is, or sorry, E, O is obstruction, which, I guess with the predominant nausea, vomiting that the patient is experiencing, certainly we could think about an upward obstruction, but most people with a small bowel obstruction, unless they experience a complication, are not going to then develop shock, like unless they've become perforated or there's an ischemic reason why this is happening, something like that. And the last one would be E. And a 19-year-old woman certainly wouldn't want to miss a pregnancy complication, whether that's like an ectopic that ruptured and then there was an infection associated with that. Like certainly that has to be at the top of our mind. And then to say, hey, how do we explain the hypoxemia? Is that just a sign that something has moved from the abdomen up to the thorax, or was there something that was predominantly in the thorax and moved down? So understanding the lay of the land as far as this patient's symptoms and how they happened will be helpful. I mean, I think we say, hey, a young person presenting with febrile illness, like to my clinic, like this is viral or sort of external organism until proven otherwise. But why for this patient did it lead to such devastation in the form of shock? And so it'll be interesting to know, like, if there's any sort of additional symptoms that led up to these last couple of days where it sort of culminated in this devastating state. I think that's where my mind is going. I think the other thread that was fed to us as well, because there's so many great pearls here, is that idea that she had pallor when she presented and then developed icterus during this time. So how can we reconcile those two things? I think once to say, if we can take pallor for what it is and then say that got worse plus icterus, then this is hemolysis until proven otherwise. How do I overlap hemolysis and shock and hypoxemia? I think there's a few different chains to connect all of them, but I think it's just too early to really try to make a lot of progress on that. But the other one is to say, hey, I'm having shock, I'm having jaundice, which I'm translating to here based off the icterus that was shared, and then abdominal pain. So there seems to be abdominal syndrome that is involving the hepatobiliary tract that is leading to shock. And we could go down that path as well. So, I think a lot to do. What would I do in real life? I'd say, hey, we're in management mode first. Probably I give this person antibiotics. I would be giving them fluids. I think about the need, do all the ABCs. And then at some point, this patient's going to need imaging of some kind to try to make progress of what's happening. But yeah, amazing start. So yeah, excited to hear the second Alec. Alec, unless you had any additional things to cover. That was a lot. There was a lot of information there.
No, yeah, I mean, I think great job breaking down shock, and I think going through the vipomnemonic, I do think this seems to be acute instead of hyperacute, and so I certainly agree that some of those other phenomenons may be a little bit less likely, and um, yeah, this is definitely management before diagnosis, although you'll be doing these concurrently. And then I guess I would love to know on an exam, was the patient warm? Were they cold? Were there signs of jugular venous distension? Those would maybe be other things that I would be looking for. But yeah, I think those were amazing thoughts. I don't have much to add. And yeah, we'd love to hear more.
So you wanted me to elaborate on the loose stools. So coming to the fever, it was high-grade intermittent fever associated with chills. And the pain abdomen was diffuse dull aching pain. And vomiting and loose stools, she just had 2 to 3 episodes, which was non-bloody and watery large volume. And she also had severe myalgia associated.
Okay, great. Yeah, thanks for clarifying those things. Do you mind sort of going ahead to the next aliquot, whatever you have, or did you want us to stop here?
Yeah, we can go ahead. Coming to the review of systems, she had no associated shortness of breath, cough, burning micturition, nothing else. And past medical history, nothing significant. She was not on any medications, no significant family history. Menstrual history, the last menstrual period was 15 days back, and she had ongoing spotting PV for the past 3 to 4 days, 1 year of married life, and no history of any substance abuse or no high risk behaviors, and no allergies.
Okay, very nice. Alec, I talked for a long time, so would you like me to go or did you want to give a shot? Okay, all right. So I guess I will just touch on a few things. As Alec alluded to before, this seems to be a healthy 19-year-old person who's not really interacted with the healthcare system up to this point. There's a few caveats to that statement. Sometimes it's just more of an access to care issue than meaning that the patient hasn't accumulated any disease. But usually that's more a phenomenon that we see in patients that have gone further in life, just because they've been able to accumulate a number of things. But it seems to be that this patient is relatively healthy. As far as clarification on the prior history, it seems that fever and pain were sort of the predominant syndromes. A little bit of vomiting, a little bit of diet, like loose stool. That doesn't seem to be what the patient is screaming about. It seems to be more of like a pain predominant syndrome. So that might help us make a little bit of progress as far as localizing like what the problem is. I found the on the review systems to not have any shortness of breath to be a curious thing. And I think the time when I sort of learned this, where this phenomena was kind of drilled into me the most was during the sort of peak of the COVID pandemic, when Alec and I were taking care of a lot of COVID patients in the COVID ICU. Was that they had this quote unquote happy hypoxia, and so hypoxemia in and of itself doesn't really stimulate your drive to breathe a lot. And so patients don't necessarily have the experience of dyspnea when it's from pure hypoxemia alone. And so that might help us to determine the sort of primary reason why this patient is experiencing their hypoxemia, as opposed for it to be less likely to be like a primary pulmonary parenchymal pathology, as opposed to sort of an incidental issue, though that certainly could happen if it's just something that's like filling the alveoli, for example. But I found it curious that she's not having significant shortness of breath to imply that there's not a lot of chest symptoms here, which then prioritizes if we're trying to prioritize the causes of shock, I think that moves us away a little bit from the thorax and a little bit. So that was an interesting reflection. And then the last was just the menses. And so the last was 15 days ago, but there's some spotting in between. So, again, there's ways that we could take that. I think right now it seems like less likely that the patient is pregnant, but I certainly wouldn't proceed through all this testing without getting a pregnancy test. So that's nice to know those things that she said, hey, I had having a period for 3 months, and that might help us move the needle more quickly. But I think there's no way that this patient would not get a pregnancy test in my mind. But yeah, it seems like the severe myalgias is the other thing that the patient is really screaming to us as a problem. So Alec, yeah, I'd love your additional thoughts on everything, and then your reflections on the myalgias.
No, thanks so much, Austin. That was awesome. Yeah, I think definitely would need a pregnancy test regardless. Sometimes patients may not know their sort of menstrual history, and then if you're going to get imaging as well, like that's something you would consider beforehand also. And yeah, the spotting, it seemed, I would love to know a little bit more on the menstrual history. Is she always regular? Did she have intermittent spotting? If this is something that is new, maybe that would point towards more of some sort of breeding predilection that we could then sort of layer in with the potential icterus, and then the hypoxia without clear pulmonary symptoms, whether or not that could be more suggestive of severe anemia or something like that, although it would have to be quite severe. And then, yeah, I guess I would love to know a little bit more social history as well. Where is the patient from? Have they traveled recently? What other exposures they may have had recently? Is there anything else that's changed in their life? Is there anybody that's been sick? But I totally agree with you, Austin. It seems like the nausea and the vomiting and the sort of mild GI symptoms seem sort of secondary, and it's really her main issues seem to be fevers and chills, significant abdominal pain, and severe myalgias. So, in a first pass in an acute febrile syndrome, that definitely thinks about a virus, but usually people don't get florid shock from that if they're young and healthy otherwise. So I wonder if there's some other exogenous organism that has more of a feature of severe myalgias, and whether something like the arboviruses, like chikungunya or dengue or malaria or things like that. So I guess I would love to know more of this, where this patient was, and I would be looking up sort of what other exogenous organisms that they may be exposed to. And then, thinking about if the patient have any weakness or anything else that could be going on. But myalgias in and of itself are fairly nonspecific. I guess I would sort of go back to the exam. Do they have muscle tenderness on the exam? Are they weak? Does she just have some asthenia? Is there anything else going on there? So it's a little hard for me to know what to do exactly with that. So I think right now I would just be saying this is a young woman with an acute inflammatory syndrome with seemingly the abdomen is the center, who's presenting with shock, and definitely would be going about managing the shock. Going for imaging, definitely a CT abdomen pelvis with contrast. And then once we getting some labs as well, see what the hemoglobin is, seeing what the white count is, making sure that the chemistry is okay, and sort of taking things from there, and then also including the pregnancy test. But yeah, I don't know if I'm ready to sort of take a deep dive down into the myalgias until we get a little bit more information, but certainly could be suggestive of some particular infectious syndromes. And I'm having a hard time disconnecting not prioritizing infection given the current syndrome. But any other additional thoughts, Austin?
Yeah, no, I think this is great. I think infectious diseases is like a real weak form to me. So I was going to bounce some ideas off for you. Thinking about an abdominal syndrome that can cause this Flaget sign or Paget signs. Like, what are your thoughts on salmonella, like typhoid or paratyphoid in this particular case?
Totally agree. I think that would be an excellent thought here, with the Faucher sign, and then the abdominal pain and diarrheal syndrome, even though the diarrhea is fairly mild. I think it's also hard to know, we do find out this patient has very significant hemolysis or does have, acute liver injury with the jaundice, that all of those could explain abdominal pain. And then anything that's causing inflammation in the abdomen secondary to that could cause like loose stools and nausea and vomiting. So I think I'll be relying on the labs and imaging to better define it. Is this, is the abdominal pain hepatitis, or is this abdominal pain colitis, or is this abdominal pain peritonitis, or is this abdominal pain from hemolysis, and not something that's from in the abdomen, right? Because there are things outside the abdomen that cause abdominal pain. So certainly salmonella would be one of them. were there other ones that you were thinking about as well?
Yeah, I mean, again, I think I just don't have a good, robust illness script for this, but yeah, I think in the absence of like a prominent diarrheal syndrome, like it seems like again a little bit of diarrhea, pain. So I think I'm kind of questioning in that hypothesis, but it came to mind. The other one would be like Clostridial species if we're trying to link like abdominal illness plus hemolysis plus severe shock state. So that came to mind, and then the what was the last one I was thinking of?
I mean, I think as well
Oh
too, like
goodness.
just
Oh
really
yeah.
bad gram-negative sepsis in general, and
Yeah,
like
yeah.
if she had pyelo or if she had you know endometritis or if she had an ovarian abscess or a ruptured ectopic or there's just the differential is super broad at this point.
Yeah, and
But
then toxic shock would be the other one that I would think about. Just like we didn't hear about a rash or anything, like including for like salmonella, like a lacy sort of red rose petal rash. I think that's what sort of I remember from my little illness script of it. But yeah, those things cross my mind. I think the only reason I brought it up is because like it might affect your antibiotic choice a little bit. Like, hey, I need to give something to help with like toxin binding in the moment. Or so yeah, I don't have enough. I don't have a robust illness script for these things, but they sort of cross my mind. But yeah, anything else? Otherwise, we can pass it back to Kritika.
no, I'd love to get to the next output.
Wonderful.
So coming to the labs, hematology, hemoglobin was 8.6 and the total counts were 6,650, platelet of 51,000, hematocrit of 28.5, MCV of 70.6, and UPT was done, which was weakly positive. And coming to the electrolytes, sodium was 143, potassium of 4.4, albumin 3.6, ALP of 67, total bilirubin of 2.3, direct bilirubin of 1.5, indirect bilirubin 0.8, SGOT of 113, SGPT 99, urea 91, creat of 3.4, CRP of 99, INR 1.48, and urine RBCs 10 to 12 for high power feed. The serology was non-reactive. And USG abdomen pelvis showed a striated gallbladder wall edema, mild ascites, and no gestational sac. And I'll share the X-ray now.
I have to say, just pause and say, I love this case so much. I can't recall ever being in this type of space before in VMR myself. So like, I'm really, really enjoying the case a lot. But yeah, excited to see your X-ray. I think Alec, you made her a co-host, correct?
I did at the beginning, but I think she had to rejoin. Let me double check and be sure that she is still a co-host. It seems like she still is.
Can you see the images?
We can't right now, no.
May I request Simi to share it? I think she has it.
I guess, Simia, do you happen to have the X-ray that you could share?
Yes, I'll just try sharing this.
Okay, thank you. Yeah, I guess while we're waiting, Alec, do you want to? I forgot whose turn it is.
I think that's all right. I think it is my turn. I'll do my
Okay.
best to remember the labs. So she's anemic. We don't have a baseline, but I presume 8.5 is not her baseline. Her white count is normal. We didn't get a differential. And she had pretty significant thrombocytopenia with platelets in the 50s if it's the same sort of units. And it sounds like she had a very significant AKI. And then I didn't get to see the liver chemistry tests exactly, but I think the bilirubin was mildly elevated and it was indirect predominant, but I may be misremembering that. And it seems like her coags were a little abnormal as well. And so we have an X-ray here, and the best I can tell, it seems like she took a good enough breath for it, and her heart seems almost. I mean, it's definitely central, but it seems maybe almost little bit water bottle shaped. And then she has like opacities in the bilateral lobes, more in the lower lobes than the upper lobes. Um, so, and then it's, maybe a small effusion. I can't really buy that on the left, but yeah, very peculiar. She has no pulmonary symptoms, so I do wonder with the severity of her illness, if this is just representative of ARDS or if something else could be going on here as well to find these pulmonary opacities, and that her heart just doesn't look normally shaped, but it just could be the angle of the imaging. So definitely something that, at least in the United States, if she continues to be hypoxic, I would definitely consider doing advanced like CT imaging of her lungs, and then just deciding based off our clinical syndrome whether or not we would be doing to look for a pulmonary embolism or not. I think right now I'd probably just do the CT without contrast, but we would have to kind of see how things are going. Yeah, Austin, did you have thoughts on the X-ray at all?
Yeah, no, the only thing I can add to that is, kind of on her right side below her last rib, there is a sort of like a calcified thing. I don't know if that's something overlying the patient or if that, because I can see one in her right axilla area and then the left axilla area. I'm not sure if that represents the same thing or if that is supposed to represent like something calcified. I am not sure just based off what I can see on this image, but that would be the only other thing I can really add. The airway seems midline. The bones seem grossly okay. Yeah.
Yeah, I think those are probably the EKG or like the tele stickers, I would imagine, just the way that they look. But
Yeah, no, it's always, I've been humbled by it more
yeah.
than once.
Oh, definitely. Yeah. I guess as a side story, I was seeing a patient once and they had like one sticker, not like four, but the read was like, oh, just an EKG sticker. And then when you looked at the lateral view, is actually in the patient's esophagus. So they had swallowed a coin. So yeah, definitely look at your own imaging before you just assume that. But yeah, do you mind going back to the whiteboard and then maybe we can keep tackling the labs?
Yeah, and then just to fill you in, we're doing that. So the liver test, as you said, the bilirubin was mildly elevated, direct predominant. The AST, ALT were like in the 100s, like low 100s. Like one was 90, one was like 100 something. And then yeah, I guess she had a mildly positive urine pregnancy test from what I heard. And then the ultrasound showed some gallbladder wall edema with striation and then a little bit of ascites and then no obvious gestational sac. Um,
Yeah.
yeah. Mhm.
So I guess just for the going over the CPC first. So the white count, I would love to know what the differential is. I think for somebody that seems to have probably, if they had a really deep bacterial, like pyogenic bacterial infection that was causing shock, I probably would have expected a higher white count, particularly neutrophil predominant. So I'm sort of wondering if this prioritizes an exogenous organism like a virus or ketchual organism or something else. But yeah, I'd love to know a little bit more about that, see what the trend is. The hemoglobin, if we have a baseline, I think that would be super helpful. But I imagine this is quite low and it could fit with the power that the patient was speaking about. And then the platelets being low, the patient has anemia, thrombocytopenia, and has an AKI. So definitely need to be thinking about thrombotic microangiopathies, particularly TTP. I would have to calculate what her plasmic score is. But I think looking at the smear, being sure doesn't she have cystocytes would be something that we'd be doing first. The MCV is quite low. I guess I would like to know if there was one previously that could suggest some underlying iron deficiency, or the patient just could have anemia related to inflammation, or there could be something else that would be going on. I think if there was profound hemolysis that was seemingly acute, I would have expected the MCV to be much higher. Just as the reticulocytosis, as long as the patient had a healthy bone marrow, I would be seeing that. So I think with the bilirubin seemingly being more direct predominant, although it could be misremembering that, perhaps that's a little bit less likely, but something that we'll have to take a look at. And then the urine pregnancy test being weakly positive. Um, little hard for me to know exactly what to do with that. Certainly, I would be very concerned about it. And so I think be trying to prioritize, getting additional testing there, whether that be checking the serum beta HCG. And then it seems like on the ultrasound, there's no gestational stack. So I guess depending on how positive it is, sometimes when the patients are super ill or if they have GU pathology, you can get some false positives. but you wouldn't want to assume that, and probably just try to do more specific testing, including serum testing. So I think that's what I would make of that. And then, yeah, I mean, she's very inflamed. The CRP was 99. I think we were expecting that. The bilirubin is 5.5, which is direct predominant. So there's no indirect component, which maybe, decreases the idea of hemolysis a little bit in my mind. And then prioritizes something that's going on in the liver, and whether that could be cholestasis from sepsis itself, or whether she could have a true, hepatic component to the systemic disease, something we'll be looking at. And then I think her INR is a little bit high, or PTT, at least for my lab, that would be a little bit elevated, but I would love to know in your lab if that's high too, and whether or not we need to be considering DIC as well in this situation. So the smear will also be helpful. And then, thinking about sending something else for intravascular hemolysis, including like a haptoglobin or potentially an LDH. And love to see that the HIV is negative, the hepatitis serologies are acutely negative, and the urinalysis with blood. Is there? I don't see that there's a 1+ protein in blood. Could that suggest something else that's kidney involvement here, or is that just related to the severity of her underlying disease? That don't get much pyuria here, so I think a GU source, like her having pyelonephritis, in theory, would probably be less likely to be driving her clinical syndrome. But in short, I think she's very systemically ill. I think with the imaging we have, the mild gallbladder wall edema, I think with how inflamed she is, it doesn't really surprise me that much to find that their gallbladder wall is a bit edematous. But I guess I would love to know if she has stones that we're seeing. And, usually if the patient is going to have severe, like a shock from a primary gallbladder pathology like cholecystitis, I would expect it to be more actively inflamed. And then even for the patients I've seen with cholecystitis, they don't really get shock until they become bacteremic or it perforates. So I'm not exactly sure what to do in isolation, but I think all this leaves me wanting more is a CT scan, because I just don't feel like I'm going to make a lot of other additional progress based from there. So I think definitely needs resuscitation, ongoing management of the shock. Need to smear urgently to be sure we're not missing a TMA or DIC or anything like that. And then probably some antibiosis while we kind of center ourselves and try to figure out what the problem is and whether this is truly an endogenous organism or an exogenous organism. Still prioritizing an infection here, and then certainly we need to clarify the pregnancy status a little bit more as we move forward. But I think those are my sort of rambling thoughts. Austin, what are you thinking?
Yeah, I'm thinking that I'm lost. I'm thinking that it's a very hectic presentation, and that again, I don't have much grasp of the problem. We have shock, we have signal in the hepatobiliary tree, we have signal in the kidney, we have signal in the blood, we have signal in the lungs. So how am I going to try to unify these things, or should I be unifying these things? I think I'm a little bit lost. So right now, I think I have to just take the problems that are going to take the patient's life first, and work to try to solve those and address those from a management standpoint while we try to make diagnostic progress and see if it is a appropriate thing to connect these things together or not. But what are the things that I can't miss that have significant management implications beyond what I would do from a base rate statistical standpoint? And I think it does center around the pregnancy aspect, I would say. So how are we going to make progress on this? This is not my area of expertise, but someone that has a positive pregnancy test, yes, like we're going to repeat it. They did an ultrasound, they didn't see a gestational stack, but just because you don't see it doesn't mean that it doesn't exist. It's possible that it exists in a different area that you did not ultrasound, or you did not get a particular good view of, or this was, the patient experienced a spontaneous abortion, or there's an ectopic that has deposited itself not in the normal sort of anatomical locations that we would think about. And then, complications of pregnancy itself. So like puerperal, well, this wouldn't really fit with that, but if we had a spontaneous abortion, it became infected, that could cause DIC. Was there a cancer related complication related to a missed pregnancy that we didn't pick up on because there was issues with access to care? Was there a clot that happened from like amniotic fluid? Again, probably we would see some evidence of these things, but I don't know if there was a story that we didn't pick up on before this that could lead us to this state. So yeah, I guess I'm a little bit lost about where to try to put our diagnostic energy at this point. I think the other way to frame it is like we have a pulmonary renal syndrome, and you kind of touched on some of those things already, but is it just that there's been an overwhelming illness, and so the kidneys are down and the lungs are down as a consequence, not that they share the same like pathologic mechanism that we can connect and need to follow like from you know, a vasculitic hypothesis or an infectious hypothesis. There's many ways to take this. I don't really know where to go at this point. So what test do I need now to help me make progress? Um, I feel like, yes, definitely want a blood pregnancy test. And if the beta HCG returns positive, then I'd definitely be asking for help from the OBGYN colleagues about what exactly to do in this phenomenon. Another way to connect like thrombocytopenia, elevated liver enzymes, the blood pressure's in the toilet. But like, yeah, is there a pregnancy related complication that I have, or a complication from a spontaneous abortion that I have not picked up on, that needs to be like surgerized, for example, which we can stabilize the patient? I don't know, but yeah, I'm really struggling. I'm not sure what I would do without with supportive care, or like leaning on colleagues. I don't know if you have any other final reflections before we give it back to our case presenter.
No, those thoughts, Austin. So I think in this situation in real time, the patient needs resuscitation, the patient needs blood cultures, right? The patient needs antibiotics, and we could debate which ones we would give, and then we definitely need sort of further clarity on the pregnancy. So I think I would be leaning to the blood, and then I just really love your point about just because we don't see it on the ultrasound doesn't mean that it's not there, and so trying to either discuss with our colleagues or figure out what other imaging we might be able to utilize in that situation, and then just sort of stabilizing it to a point where we can get additional diagnostics. But I feel like it's going to be very difficult to make further progress on this test without, on this case, without some like enhanced further imaging of the abdomen. The ultrasound is never going to be good enough. But yeah, I would love to get some more information.
Going on to the additional labs. So when we repeated the CBC, there was a drop in the hemoglobin. It was 8.1, and the total counts increased to 16,200, and the platelets dropped down to 18,000, hematocrit of 26.8, and the bilirubin was 5.5, indirect more than direct, SGOT of 81 and SGPT of 48, and the urea increased to 122 and creatinine to 4.2. Blood cultures showed no growth at 48 hours of incubation. Beta HCG was negative. Procalcitonin was 77.36, and the D-dimer was more than 15. The reference is less than 0.5.
Austin, I think you're up, unless you want me to go.
Okay, yeah, I had to take off my jacket because I'm sweating about this case. So, yeah, so unfortunately, we've seen progression of this patient's disease. I'm not sure like what particular antibiosis or management they received, but I think the other thing here is that we do seem to have, maybe I misinterpreted the labs initially, but it seems like we do have a signal to hemolysis at this point. We don't have any other of the hemolytic labs as far as like a haptoglobin or an LDH, but we seem to have an indirect predominant hyperbilirubinemia with a declining hemoglobin, and low platelets as well. So I think that's a space that we're going to have to explore. And when I calculated the plasmic score a bit ago, Alec, it was sort of like intermediate on depending on how you interpret certain things. But I think that would definitely be something that we're going to have to consider at this point in time.
Austin, I think it's direct predominant. I think it's 5.5, and then direct is 4.2, I think.
Okay, I guess maybe we can have Krithika clarify for us. I thought she said it was more
Yeah, I would like
indirect
to
predominant.
clarify that it was an indirect predominant.
Okay, very helpful. Thank you so much. So the indirect is 4.2 then.
Yeah, I don't know if we have the exact number, but it is indirect predominant. So I think we can say that we either have an issue in the liver inherently with conjugating bilirubin, or we have we seem to have a clinical syndrome of hemolysis here. So how do we make progress on that? We need a smear for sure, as Alec alluded to before. We'd probably check, based off the MCV, probably we're not experiencing like autoimmune hemolytic anemia, but I think we want to make progress on that with a DAT for sure. We're definitely going to calculate the plasmic score and determine if we need to start this patient on plasma exchange in the meantime, while we're awaiting the results of those testing. I think the other thing to think about again is infection. Like, what infection can cause hemolysis plus sort of severe illness in this sense. I think we touched on some of them before. So I don't know if we need to. I'll sort of leave it to you to touch on them individually. I don't know if we ever had a CK, just with like severe myalgias. If we go back to that, to try to see if that can help us make progress with what I believe to be an infectious syndrome here. Yeah. Again, Alec, yeah, I'm struggling. I'm really struggling. I'm not sure how to unify everything together when there's so much hecticness. I think we definitely need to prioritize the hemolysis hypothesis here. I think we've exonerated the pregnancy issue. The only challenge about that is if we had a spontaneous abortion and days have been going by, then presumably the beta hydroxybutyrate will go down. So at least there's not a live pregnancy that's there, but it doesn't mean that it's not causing complications. So that's, again, something I'd have to lean on my colleagues to help me with. But yeah, I think the other thing to make sure of with, abdominal pain, we could have an explanation for that. But again, I think imaging, it would not be unreasonable in this case either. Yeah, I really don't know. I'm struggling a lot. What do you have?
No, I don't think you're struggling at all. I think this is a very difficult case. I think just to reframe ourselves. So, this is a 19-year-old woman presenting with an acute febrile syndrome complicated by shock, with lab significant for progressive anemia, thrombocytopenia, increasing leukocytosis. We didn't get a diff. I presume that's neutrophil predominant, but I guess I would love to know that as well. And then indirect hyperbilirubinemia with elevated AST and still pending a smear, but signs concerning for hemolysis, and with a very elevated D-dimer and elevated coags with potential component of DIC, and then very profound acute kidney injury as well. So, I think at this point, I agree that we've exonerated the pregnancy, and I think at this point she is so ill that we need to figure out what's going on. And even if she is pregnant, radiation from a CT is like more likely to save her and the baby than it is to kill them. So I think for me personally, we have to be sure she doesn't have some sort of intra-abdominal catastrophe that needs, acute intervention upon. And then I think, with the progressive anemia, thrombocytopenia, with the febrile syndrome, it would definitely be prioritizing organisms that could do that. So I love your idea of clostridial sepsis because of that, just the morbidity of that and how that would change antibiotic management. Sorry, Mike. And then another thing that I would be thinking about as well is just malaria. I don't know if where this patient is located, if malaria is located in endemic in that area, but something I would be considering. And then also like some of the other viruses like dengue and chikungunya, although the profoundness of the hemolysis is also quite striking. But then I know sometimes some of these infections can be associated with associated bacterial infections, and patients can have poor outcomes with that. But I think at this point, the patient needs further imaging, at least to me, to be sure there isn't an intra-abdominal catastrophe. We need to get a smear, and then the patient just needs ongoing and supportive care. And then I think some further addition about the hemolysis, like what the haptoglobin is and what the LDH is, I think would be further playing on that, just because we don't want to miss a TMA from the morbidity. But I feel like whatever's driving the anemia and thrombocytopenia and the hemolysis is either DIC related to a really bad infection, or an infection with a fingerprint into the hematologic system that can cause hemolysis. So I think those are sort of my thoughts. But Austin, what are your thoughts before we get more information?
None. Let's get more info.
So this would be my last teleport. Shall I go ahead and tell the?
So
yes, please save us.
You're gonna tell us the diagnosis now, or are you going to give us more information?
Yeah, I'll just give you the results of the fever profile. We got a fever profile done, which came positive for dengue IgM and leptospira IgM.
Okay, wow. So the patient had concurrent dengue and leptospirosis. That's fascinating. I would love to know the patient's exposures for that. So dengue, I could definitely fit with the fevers, the acute syndrome, the myalgias. It definitely isn't fitting with dengue. The leptospirosis, um, you know, could play in to the kidney injury in particular. The bilirubin being very elevated, certainly you can see that in leptospirosis, but it's usually direct predominant, not indirect predominant in Wheels syndrome. But it could be the overlapping the features is what made this very difficult to diagnose. But I think a great example of this patient hopefully would have been started on doxycycline very early. And then, unfortunately for dengue, it's just all supportive care. And then I guess I wonder with the pulmonary features, was that just thought to be ARDS, or did she have some sort of, like pulmonary hemorrhage, DAH component as well? And then in the patients I've seen with dengue, they usually have this, hemoconcentration phenomenon where the hemoglobin is, quite a bit higher than the platelets. And so I guess I would have been reconciling that in the meantime. But what a case that was. I definitely was struggling through it. And thanks so much for sharing. I'd love to hear your reflections, Austin, as well.
Yeah, wow. I think I need one of these infectious profile tests where I work so that we can get dengue and leptospira, because I definitely wasn't thinking about two concurrent infections, but no, I think again we were struggling to piece everything together and trying to unify them into one hypothesis, I think led us astray. And so what travels together, and certain infections can travel together, certain autoimmune diseases can travel together, vitamin deficiencies, like there's a different diagnosis for these things. But I think when you have a lot of hecticness, I think you have to take a step back and say, what is there a possibility of having two concurrent things going on simultaneously or more? And oftentimes we invoke that possibility in patients that have like HIV, for example, or have a transplant and are incredibly immunosuppressed. I guess I wasn't thinking about it in this lady, but I think that's a bias of my practice pattern in the United States, where I've never seen a case of dengue, and I think I've never seen in real life a case of leptospirosis yet. I probably have, but missed it. So I think, that's helpful. I think if we go back and say, I'm still not uh, exactly sure the hemolysis component, unless we're saying the patient had like DIC. The the Certainly the combination of like neutrophilia and thrombocytopenia does speak to certain types of infections, of which leptospirosis is on that list. I think the other clue was like the profound renal injury with the potassium being 4.4. So we've seen that a few times in VMR, where there seems to have a sort of unexpectedly lower potassium for the level of renal function. And that could be a feature of leptospirosis. The muscle issues, yeah, could certainly fit with dengue. The pulmonary issues could overlap with leptospirosis, and I guess severe dengue infection, as you alluded to before. But again, there's a little bit of a disconnect here, and it's possible that like severe features of leptospirosis combine with severe leptos of features of dengue, and then form this pattern that's like somewhere in the middle. That's like, wait, what in the heck is going on? And then we just have like cytokine hand waving storm happening, and the labs like we're having a difficult time piecing those things together. So yeah, a lot of reflections on this case. I'll have to go back and listen to my discussion and see where I could have made progress better. But yeah, I can't imagine taking care of this patient in real life. So please tell us your reflections and how the patient did. And, thank you so much for sharing such a rich case.
Thank you for giving me this opportunity. But the patient deteriorated very fast. She didn't make it. So we had to intubate her on day 2. And we gave her several STP transfusions and whole blood transfusions, FFP. And we did everything, but we couldn't save her.
Yeah, thanks so much for sharing. I think not unexpected for just the severity of this patient's presentation, and sometimes has happened. I'm just curious about how you were synthesizing everything together, and how you got to dengue plus leptospirosis, if you guys were already thinking that, or if it was just the infectious testing that you did that gave you the answer. I'd love your reflections on that.
The thing is, back here from where I come from, dengue is very common, pretty common. But the combination of dengue and rickettsial fevers and dengue and leptospira, it is very uncommon. So this was new to us as well. So it took us a while to come to the diagnosis and then treat her. And there wasn't much time for us to do anything. So it was one learning experience.
No, thanks so much for sharing about the patient. I'm sorry that she didn't make it, but I know you guys, did your best. This was such a challenging case. I couldn't imagine being a part of it, especially having two of those diseases together. And I just want to applaud you and your team for doing everything that you could. But yeah, Austin, any final reflections, or not to reflect more on this? But I guess anything else before we maybe pass it to Vinny to do the teaching points?
No, I think the going back, like we were worried about like an abdominal syndrome and all these things, like, and we never really like fully clarified exactly what was happening in those moments. Maybe it was just, the liver was causing some inflammation and causing pain. I'm not exactly sure what was happening. And so I'm trying to figure out how we could have gotten to this diagnosis sooner. And I think stepping back and saying, hey, young female, or it doesn't matter the gender, but young person presenting with acute febrile illness. We talked about exogenous organisms very early on, and we talked about the severe infection, like with viruses in a young person is relatively uncommon unless there's like a predisposition. And so that should have led us to prioritize an exogenous organism like dengue, or these I guess atypical viruses from my perspective. Obviously for other people in the world, like dengue is like a normal thing, but for me, like thinking about more of those illnesses first, like probably from a base rate statistical standpoint, like we should have started there. And then from there, like saying, hey, okay, what about this presentation doesn't fit with dengue or these other viral, like hemorrhagic fevers, so to speak. And I think that's where we would have hopefully been able to make progress. But there's no way, like in real life, I would have made this diagnosis. And so I'll be entirely authentic about that. Like I would have there's no way I would have sent. We don't have a panel, so like there's no way I would have sent a leptospira serology like on day one, like zero chance. And then probably when I got the labs and saw the combination of like thrombocytopenia, liver enzyme elevations, and white count, like maybe I would have added doxycycline right there just by how sick the patient is. So like never let a patient die without doxycycline is like the mantra that I learned in the ICU. Those are my like real time and authentic reflections. I don't know if you have any, Alec, before we pass it on to Vinny to have the monstrous task of summarizing this case.
No, I really appreciate that. Yeah, I mean, I will be authentic as well. There's no way I would have sent a leptospirosis. I think based off the where the patient was from, I think if I knew a little bit more about the social history and the exposures, maybe I would have sent the dengue a little bit earlier from the things that you mentioned. I don't think the idea of a concurrent like bacterial infection would have really crossed my mind quite as much until the neutrophilia became more predominant. And then I think at that point I would have tried to just think about the case and like um, if she had come in with the day 2 labs, would that, or the day 3 labs, like would that have changed the differential? And then just thinking about it, the exposures. But even then, I definitely wouldn't have gotten it. So very humbling. I've only ever seen one case of dengue, and it was like a textbook. And then leptospirosis. I got lucky on history one time, but they're just not common things that we see. And then them together was unfortunately tragic for this patient and made it very difficult to diagnose. So yeah, it was a tough one. I really appreciated going through it. And, thanks to Kritika for presenting the case, and thanks for Simi for doing all the scribing. And yeah, Vinny, enlighten us. Hey, Vinny, I don't think we can hear you, or maybe it's just me, but.
This is a sign of a true expert troubleshooting in real
I
time.
think
Oh,
that now you
just
can
hopping
hear me
over
okay.
to thanks Julia for coming in the clutch.
Sorry about it. But anyways, yeah, amazing reflection. So what we can say about the teaching points and reflections. At first glance, we had a 19-year-old lady that presented with acute febrile syndrome and with high pretest probability of an infection, also with myalgias and shock. So in this case, we need to do first management and start with replacing fluids and starting antibiotics, and then we can do a more profound evaluation. So after that, we could see that the patient was deteriorating and labs revealed AKI at a high traceability with an indirect component and a negative pregnancy test. Also, what was intriguing was the high and increasing white blood cells that is most consistent with the bacterial infection, but besides the fact that we didn't have the differential. But after we managed the patient initially, and now we are diving deep in the clinical reasoning, we should see if this is a distributive or obstructive or cardiogenic shock. And we need to see what is the source. It is skin, it is abdominal, it is a perforation, what is it? And then imaging would help to clarify what we are thinking. And besides that, we thought that this mirror would enlighten us, but also we can see that just with if we don't have the smear, and we can see the patterns of the hemolysis that can also align us in an alternative pathway. So also to the exposure history of the patient and the regards the epidemiology, we can proceed with an NS1 test or even NS serologies. And due to the high the thought about the leptospira, it was sent a panel and it came back positive. So so we can see a patient can have as many diseases as they want, and it is even for us and even for me that lives on a very common epidemiological environment of dengue, is not common for sure to see and superimpose bacterial infection on dengue. So that's outstanding. Thank you for the case, and thank you guys.
Yes, amazing summary and audio troubleshooting, and thank you so much. And yeah, thank you so much to Ritika for presenting such an incredible case. And we hope all of you will come and share your cases as well. And we hope that Ritika will be back to give us another case. I hope I'm not the one discussing the next one. But yes, amazing. Thanks so much, Simi and Vinny and Ritika, and I think Alex, he's wrangling his kids that were trying to enter the room while he was doing this discussion. So we'll end here. Thank you so much, everyone. Bye-bye.